Recording.
All right, well, folks, it's like I said, Casey Boyd here, KBMO. Thank you for attending our ongoing series. Today we have a distinguished speaker who has been using KBMO for now about 7 years, Dr. Dimple Joshi. I'd like to introduce her. She is a board certified as a functional medicine provider and a holistic health doctor, and holds her medical doctorate in alternative medicine. She also attended the Medical University of South Carolina. She graduated from there, and she has a passion for learning the root cause and the root problems of disease. She is traditionally trained, primarily she looked at cardiology in the beginning, but I think you'll find out when you kind of hear some of her experiences and how she utilizes some of the newer tests and some of the things in her practice, you'll get a great feel. Please feel free to use the chat. Please mute your phones if you don't mind. And I will keep up with the chat, but as we go along, we'll have a Q&A period at the end. So I'd like to turn it over to Dr. D.
Hi, everybody. Thank you for having me. Can you guys hear me okay? Okay.
Yes, we do. Yes.
Okay, so I'm Dr. D. I'm going to be talking today about Heartfelt Harmony, Cultivating Cardiovascular Wellness by Taming Inflammation. And I'm going to tell you a little bit about my practice holistically. Hold on, let's see. Oh, goodness. Slideshow issue, hold on. Okay, so I'm going to be talking about my practice, Holistically Healthy. We're an integrative alternative medical practice located in Greenville, South Carolina. Basically, like Casey said, the focus of our practice is true root cause medicine, not just Band-Aid for symptoms, or, we don't try to do that unless we really need to. We're one of our biggest areas of concentration in our practice is cardiovascular medicine and cardiometabolic medicine. My background is pretty extensive in the cardiology world, and I wanted to take what I have learned years past and bring it to a new cutting edge type practice style that we've been doing here for some time now. To do root cause medicine, seeing my background in cardiology, we used to do practices where we see people go through their, risk factors, modulate those risk factors, and think somehow that was like getting to the root of what is causing their major issue. Well, through all my experiences, both personal, professional, I've learned that that's not true root cause medicine. The real root cause is trying to figure out why somebody has what they have. And so I've sort of formulated my practice in such a way that we really work from a pyramid style where we have the base, where we are really trying to get to find out and investigate the actual causes that may be underlying what is ailing people these days in regards to symptoms, chronic conditions. And we really offer a lot of extensive functional medicine testing, advanced diagnostics, just to be able to really, truly investigate people's bioidentical or biochemical individuality. So that's really what our goal is. We try to advocate for our patients all the time that have limited options in the conventional world only, and we offer alternative pathways to them. And we do an integrative approach, and we'll talk about that a little bit later on, but we really try to be a voice for our patients to get things that they don't get elsewhere. And so let me see if I can change the next slide. In our presentation today, we're going to talk basics about inflammation. I'm sure a lot of you already know about inflammation and all that, but we're going to just really focus on what it means from a cardiovascular standpoint and how we're using functional medicine, integrative medicine to deal with those things. We'll talk about advanced testing. We'll go through some case studies for some of our patients that we have here. And then we'll talk about what types of patients we typically enroll in our clinic. And then, whatever questions you guys have. I like questions more than a set agenda. So we'll talk more about the questions and answer those towards the end. But I'm going to try to go through some things basically in the slide presentation, and then we can talk a little bit more thereafter. Okay, so let's get started here. Okay, so basically in regards to inflammation, what we're gonna talk about is basically we all know that inflammation is something of our body's natural response to when we get injured or we have an infection or something external comes in, and it's just our body's way of dealing with that. But inflammation does play two roles, typically acute and chronic. And the acute is what our body's trying to protect ourselves, fighting all these different things we get exposed to or injuries we have. But the chronic inflammation is really what we are trying to solve in our clinic. We really try to get to the root of why somebody has this chronic inflammation and all the different sequelae of events that happen because of it. Typically chronic inflammation is a prolonged, I'm going to read you what I wrote out here. It's a prolonged and persistent response characterized by a sustained activation of the immune system. And basically what ends up happening is with all this chronic inflammation, long-term, your immune system just stays in this state of alert and it keeps releasing these signals. And then eventually your body just starts displaying these symptoms. We'll talk about that here in the next slide. We fill up this bucket of inflammation we have with all these mediators and our body's immune system response. And eventually our bucket starts overflowing and we start getting all these symptoms that develop. So in the general medical world, there are people come in with, all kinds of non-specific symptoms, blood pressure variations, digestive issues, can't lose weight, can't handle stress appropriately, pain, obviously, mood changes are big. We see hormonal dysregulation is huge. Headaches, brain fog is a big one we also see, and fatigue. I mean, these are typical presentation of, patients that come in all the time with these chief complaints. And so we find that it's all this chronic inflammation that sort of keeps building up in our system, all this external stimuli, trauma, infection, toxins, whatever you call it, all of it building up, leading to these types of symptoms. And then long-term exposure to all this, leads to these chronic conditions that people develop: cardiovascular, autoimmune, metabolic, bone, joint, all these types of chronic conditions. There's also genetic factors that are involved in some of these things, obviously, environmental factors, stress factors, lifestyle factors. But the base of everything is this chronic inflammatory process that's going on at a cellular level that sort of comes about as these conditions later on in life. And what our goal is twofold. One, when people come in with symptoms, to sort of work at that root cause of inflammation and try to sort that out. And when people have these conditions, we figure out what we can do to backtrack some of that and see if any of it's possibly reversible, or at least get it to a level where things don't progress. And so that's sort of our goal in our practice, that we try to really, advocate for our patients. I'm going to talk about cardiovascular specifically, not all those ailments, but what I want to really sort of say is cardiovascular health is a very important topic, obviously, right? The cardiology, our heart is a very important organ. A lot of, issues happen because of this, but there's many different ways to deal with cardiovascular health. When I first started, it was conventional long ago, and it was conventional medicine. I'm going to go through a little bit more about the conventional presentation of a patient shortly, but conventional world, then there's alternative medicine. Now that's the other extreme, where you're not really using any mainstream practices. You're using more like homeopathy, acupuncture, other things that are not conventional, but just an alternative way of dealing with this. And there's a space for everything here, but where I really focus my practice now is more of the complementary, but mostly the functional and integrated part of things. So functional medicine is really the part where we start from addressing the imbalances people have, and we really try to work on balancing those imbalances and trying to really investigate why somebody has what they have. I feel like I should have been an investigator in the beginning of life, when I started, deciding what I wanted to do when I grow up. But, this is the best of both worlds, where I get to really investigate why somebody has what they have and really get them to optimal health and wellness. Given my background in conventional, I really do try to do evidence-based practices. And so this integrative world of mine is, a good encompassment of my conventional world, my functional world, my complementary medicine that we practice. So it really does give me the best of all worlds now, the way I am able to practice. So I'm very grateful for all the research, all the companies, all the pharmaceutical grade supplements, everything available nowadays has given me the opportunity to be able to practice really a whole health way of living life for my patients. So that's been a really great thing. Okay, I'm going to go back and talk about so when we see a patient in the conventional world, whether it's a cardiology practice or internal medicine practice, you may have a patient, just sort of say, for example, we have somebody that comes in that wants preventive care, meaning they have a strong family history of cardiovascular issues, and they're really just looking to figure out how to not exhibit these things when they grow up. They're just really wanting to be healthy moving forward in life. Well, going to a cardiology or internal medicine practice, you may get your typical history, physical, symptom assessment, you get some labs ordered, maybe some diagnostic studies if maybe that, and that's a maybe because we're probably not going to do too many if you're just having some risk factors. Then we may do vitals. Hey, your blood pressure is a little bit elevated, or let's order these labs. And when those lab results come back, your cholesterol is a little bit high. We got to deal with that. Oh, your A1C is just a little bit high. All these little borderline numbers that people have this elevated risk factor profile all of a sudden. And so now you're being told that you have these risk factors. Yes, you have family history, genetic, all that stuff you have. But what do you do with that? So in the conventional world, they may be like, well, dietary recommendations like DASH diet or Mediterranean diet, do some exercise, and if your blood pressure is elevated, they may give you a script for, metoprolol or, whatever, some sort of medication to sort of help with that. But that's not really getting to the root cause of why they even have this slightly elevated blood pressure or, abnormal cholesterol profile. So that's not a sufficient way of saying what is causing somebody's future cardiovascular issues. So what we really want to do is do this functional medicine or integrative approach. And what we really do, that same patient coming in the functional world, we would do an in-depth, evaluation. Obviously, my typical patients come in, I spend about an hour and a half with them on their first visit. And we really talk through all of their risk factors, figure out their lifestyle, where they live, what they eat, what they wear even, what they do for a living, all this total encompassment of what, their daily life and what their past is about. And then, we go through, let me move the slide over. Then we, go through what we would develop as a plan or a strategy for them moving forward. So now we've got this whole history for them. Now we're going to decide what kind of testing. So if you recall earlier, I said we start with the pyramid style presentation to functional medicine, where the base is really the foundation that's going to help them get to optimal health. So what we want to do is figure out what is causing all their symptoms. Well, most of us all know that inflammation and stress are probably the two main root causes of everything that ails us when we move forward in life. And if we can figure out what is causing that inflammation, those triggers, the gut brain, the gut heart, the gut skin, all that, so the gut is a very important part of all of this process that we do. And figuring out those inflammation triggers is going to really help us make them, give them true preventive medicine, if you want to call it that. So the way I go about my next stage is when I see somebody, we get their history, we do everything. Now we're formulating the stage 2, where we're going to formulate their strategy of what testing we would recommend. I always tell my patients, yes, I can offer you all these different therapies and recommendations, but it's not really going to be about you. You're not going to know what's wrong with you until you really know. So I would say in 95% of my patients I've had doing this practice for the last so many years, 7, I guess, Casey added up for me. We basically start with food inflammation test. I recommend an inflammation test for my patients because that is the one thing we can control. I can't control inflammatory triggers that may be all environmental, or I can't control all your stressors in life, but what you do have control over is what you put in your mouth. And so my dialogue with my patients is, this is one thing that you will always have, that you will know what is causing some issues in your body. You may feel them, you may not feel them. They may be at a cellular level, they may be something causing gut issues, joint pain, whatever. But that is one thing we want to do. And then in addition to that, we do a detailed cardiovascular, inflammatory, metabolic marker panel for them. And the reason for that is I want to know where they are cardiometabolically. And then once we get our gut barrier, our food inflammation test, once we get all that stuff back, we put everything together and figure out what is actually going on in this patient at a biochemical level. And so once we figure that out, and we also do micronutrient deficiencies, that's the other thing we do. And so now we bring them back in a second visit, and now we're going to go through this whole plan of action for them. Let me see if yeah. So I think I talked about some of this earlier in terms of what type of testing we do recommend. And then we'll talk about some of the protocols here in a minute when I go to the next phase. But the food inflammation test, why this test versus another food sensitivity test? That's another common question I get all the time. Well, the store has, this other food sensitivity test. Why can't I just get that one versus why do I have to get this one? Well, the answer is quite clear. We used to use other food testing long ago. And what we've learned is this test is very sensitive, very specific, and I actually see the patients benefiting from that by doing this elimination, whereas some people have already tried other testing before they've come in, and they're still not getting to where they need to feel great. And so then we will even tell those guys, hey, I know you had this test before, or another food sensitivity test. Why don't you try this food inflammation test, because it works differently. And if you research the pathways, it makes a lot of sense of why you're only getting so many, things that are reactive versus maybe in a sensitivity test, you might get a lot more. So we find is that the food inflammation test really gives us a set. It's not this infinite number of things that are all positive. There's a very few select things that are very positive. And so what we figure out is you've got this test, that mixed with the gut barrier test, that mixed with the cardiac inflammatory test, all that together is really giving us an idea of how something is affecting them. So we do that test. The other test we do as a foundational is a stool test sometimes. So we do a stool test, just assess what the microbiome is doing. And then on that same topic, along with the inflammatory markers for blood work, we also do a blood test called a TMAO, which sort of the gut-heart connection. So we do add that test in place as well, just to get another piece of the puzzle to see how much the gut is affecting the heart. And so that does really help us out there. We do a lot of other testing as well. I don't want to get into all of those, but for the first phase, those are typically my baseline foundational testing that we do for our clients, just because this is going to give us a good eye into what is going on with them. Let's see where we are here. Okay, so what I really like about the food inflammation test with KBMO is that, you see the bar graphs, it's easy to read. The patients really like that. You can really just see what, is really bad, what's okay. And then this whole gut barrier panel with it really helps to sort of see what the foods are really doing to the body. Do you have leaky gut? Is it stability issues? Is it, what is going on, with your gut? The candida aspect is huge. A lot of people have underlying candida that causes a lot of those other non-specific symptoms. So it's really good to have that to sort of see what phase of this increased intestinal permeability or leaky gut that our clients are in. So let me see if I have this is a little bit.
Padre,
somebody say something? Can you see it or no? Okay, I think it works. So if I had a patient that came in with this test here, what our protocol would be, this would be the second visit.
Pues vengo a causar un caos ahí en tu cama.
Can some,
Y yo que la acabo de...
No, mira los sentidos, porque sabía que no se venía a hacer esto.
Sí,
Lo
claro.
presentí. Mira, mira. Déjame que traigo las toallas.
Dr. D, I think you're muted.
can you hear me?
Yes. Perfect.
Okay. Sorry about that. Can you see the screen?
Yes.
Okay. All right. So sorry about that. I don't know how I got muted. So when patients come in with this result, when we go through this result, my strategy is to do a personalized elimination diet based on this study. And what we do is I eliminate everything from the light greens, even though they're mild. And typically when I've talked to the advisors at KBMO, they say those are sort of, maybe you can or you can't. There's a mild and you don't really need to worry too much about them. But for my practice, because I'm dealing with more of the cardiovascular patients, I want to eliminate any possible inflammatory triggers. So what I'm doing is I'm eliminating the light greens to the reds. We eliminate everything for 6 to 8 weeks minimum. And then we start reintroducing just the light greens initially. And we'll introduce them every 3-4 days after about 6 to 8 weeks, depending on what we see and what the gut barrier is. So a lot of different variables come into play. So that's strategy one, is this elimination part of things. Then we go through our other results, which I'm going to show you in the next slide, which will be more of the cardiovascular inflammatory markers and metabolic markers. And we'll see what's going on with their systemic inflammation level, their metabolic issues, and we'll sort of see which way to formulate the treatment strategies. So depending on when we see people in their path of cardiovascular medicine, whether it's just preventive or they have diagnosis of hypertension or dyslipidemia, or they even have cardiovascular history of stents and heart attacks and cabbage. We see the full realm of everybody. So we try to phase our approaches depending on what part of their journey they're coming to us in. So we read these numbers based on that, really. But once we get all of the information, our first phase is an elimination phase. I'm just going through my protocol just to give you an idea of how I use it in my practice. We use an elimination phase. So elimination means elimination of food triggers and pathogens. So like I do a stool study as well. So we eliminate the pathogens. So basically we use an antimicrobial agent to eliminate that, and then eliminate the food inflammation triggers. So this is phase one for us. And then we move on to more of that gut healing, depending on if they had the leaky gut markers, Candida, LPS, whatever markers they had. Then we move on to phase two, which is more of that gut healing protocol. So what we use for that are products that have L-glutamine, aloe vera, we use some probiotics, and probiotics are a little tricky for us because we also do a lot of mast cell activation syndrome patients. We see a lot of those patients, and so some of those probiotics are reactive to them. So we're pretty careful on what we pick for patients. But basically the gut healing protocol is the glutamine, aloe vera, we do vitamin D, and we do omegas. We use many different brands that are, tested, obviously, from biotics to designs for health to integrated therapeutics to orthomolecular. So I'm not brand specific. I really like to see which company has the best product with the least added ingredients. Really, that's my simple philosophy. I don't want, to have too much of a supplement profile that has a lot of stevia. I try not to use a lot that have magnesium stearate. So that's a personal thing for me, just based on our patient population, that we don't try to do too many supplements with any of those additives. So we really formulate a plan of action based on what each individual patient needs. So our protocols are per patient, very individual. We do not have a set protocol because, say, turmeric comes up for somebody. Well, I'm not going to give them an anti-inflammatory agent with turmeric instead, or curcumin. I'm going to use something with boswellia, which is also a highly potent, anti-inflammatory. So we really adjust our protocols to each person individually, and that's how we sort of function. All right, let me just make sure. Okay, these are some of the other markers we add on in addition to those other cardiovascular inflammatory markers. Being a cardiology-based practice, we really try to get deeper into the endothelial system, and so we check this LPP(a) activity, MPO, oxidative LDL, I think that's on there, ADMA. I check that because I want to see the nitric oxide level. I'm sure there's the strips and stuff like that, but these are things that I like to do. Ferritin and uric acid, just some other inflammatory markers. We do some of these other testing that I think I've talked to you about that earlier. Let me see. All right, so this is one of those pictures that I like to use to show my patients of why we pick these different markers. To look at, to see what stage their endothelial, lining and, the state of their vasculature is in. So I'll pick, things from the oxidative LDL to the HSCRP, to either the MPO or LP(a), depending on what's going on. And we don't want to check the troponin. Those are all my back in the day cardiology type things we would do. I don't plan to have any patients needing any of those advanced labs, but we want to see where they are in their, plaque formation. Do they have any, or are they just in the very beginning stage? How aggressive do I really need to be for this person? And that's why we do some more advanced inflammatory markers as well. This is another great slide that I show my patients in terms of the whole panel. So basically, your house is, this little plumbing, we talk about that, and we want to keep the pipes clean. Well, when you have cholesterol, you're trying to really figure out what type of cholesterol you have, because if you have the wrong type of cholesterol, you have the stickiness of your blood vessels, you have the smallest little particles of bad cholesterol. That's going to all eventually get stuck somewhere in your blood vessels. And then you add in the inflammatory mediator circulating around due to foods people eat or other issues really, relating to inflammation. Well, that adds in terms of more clumping of all of that. And then you bring in the metabolic part of the picture where you have this glucose circulating around, insulin resistance, whatever picture, but the glucose, scratches those blood vessels up, and then these little fat and inflammatory mediator clots are going to be circulating, and they get stuck in these little areas of the blood vessels. And then you throw in the genetics with that. So now somebody has some genetic history for stickiness of blood vessels or other inflammatory markers or susceptibility to clotting, things like that. Now you're setting yourself up for blood clots, right? Or MIs, strokes, whatever. But if we can get to the root of fixing the lipid panel by getting more, specialized lipid studies, like you do the NMR fractionization or the ApoB. Obviously, that's like really big in terms of preventive for strokes and heart attack, to really see the, the size and functionality of that. Also, the oxidative LDL, the oxidative stress level that's being carried with the LDL, that's important for us. Let's see what else. And then we do insulin. We do a fasting insulin because I really want to see if there's an insulin resistance or, a decreased insulin sensitivity with all this glucose that may be circulating around. So this picture really helps our patients sort of see what going on in their blood vessels. And so it helps us just give them a picture of why we're doing what we're doing. And they can sort of see, even though I can't feel it, you know, I can see what you're talking about within our vessels to see like the little small cellular level damage that may be happening. So this is something we do use in our clinic often. And in fact, I actually have a big picture of this so we can just show them and point to it. And they really do like something like this. Visuals do really well in our practice. And so we do try to keep that. This is just a slide that I have that basically just shows how cardiometabolic, risk factors lead to true cardiovascular disease and the different parts of the pathway where you can get to those risk factors and really solve that root cause of those risk factors by either, stopping genetic expression by biohacking what's happening, getting the insulin receptors more sensitive to avoid the glucose from freely circulating, getting the right lipid profile. You can't just base your statin prescriptions on a calculated LDL. You really need to get a direct LDL. You need to get more detailed of the size and functionality of the LDL. And you also need the right HDL. Just having a high HDL number doesn't mean anything if it's not the right big fluffy type of HDL. So we really try to work through all of those aspects for each one of our patients. And it really does work well for them in the end when they get the benefits of getting their symptoms reduced, or getting, seeing the numbers of the HSCRP coming down or the oxidative LDL, reducing. I didn't mention homocysteine, but homocysteine we use all the time as well. And it sort of just gives us an indirect indicator of oxidative stress as well. So, those are the types of things that when they see the numbers coming down, they get excited that, oh my God, this is something that's, actually working for me instead of just giving me a script for something or telling me to go do this exercise or do this diet. It's actually seeing them go through the process of, what's happening with them and seeing the changes that they're experiencing. Now, this is just for if we had something preventive type people. I'm going to talk about some case studies here where you'll sort of see, just a typical patient. So I'm just going to start with this. I can't interact, so I'm sorry. I'm just sort of speaking, but I'm going to try to do this and answer any questions, hopefully, after this. We had a patient named John. He was a 45-year-old. He came to us with a history of hypertension and cholesterol. And his basic complaints to us were fatigue. He got occasionally dizzy. And then he had a hard time maintaining a weight. He tried diets, he tried exercise of different sorts, but he was not really getting that weight off. His blood pressures, I recall that they were elevated, but they were like in the 130, 140 systolic range. And he was put on metoprolol, 50 milligrams, and then he got tired in the afternoons. He had some joint pain. He had some of these non-specific symptoms as well. What we found was he came in, we did his whole evaluation, we did the food testing, we did the inflammatory marker testing, and what we discovered in him was that his food showed gluten and gliadin, that specific protein of gluten. It had casein, but it also had, those are the big ones, right? Dairy, gluten, those are typically big. But he also had kale and coffee. Like kale, obviously healthy usually, but apparently for him, it was producing an inflammatory reaction. On his gut barrier, he was positive for candida, zonulin, and occludin. So, we definitely have leaky gut happening with him. And then we did his inflammatory markers, and that the HSCRP was elevated, his ApoB was elevated, his LP little a was elevated, direct LDL, and A1C was, I think it was, his A1C, I believe was, the other one I didn't write here was insulin, but his A1C, I believe was like 5.5, not really elevated conventionally, but from my perspective, I like it to be less than 5, ideally. I know that's a little stretch sometimes, but ideally less than 5. And his fasting insulin was actually 19. So I think optimal insulin, if you can get the optimal sugar levels, is about 2 to 6. So I like to sort of see that. And so an insulin of 19 with the A1C a little bit higher gives me some, red flags to be like, we need to work on his metabolics. So what we did with him was we did a personalized elimination plan. We took away everything for 6 weeks. And then we introduced some anti-inflammatory supplements, some that I like. Oh gosh, I'm drawing a blank on the names. Inflammatone from Designs for Health. We do some Boswellia. We do, gosh, now I'm drawing, the omegas. Sorry, we do omegas, high potency omegas. Metabolic support, we do berberine, we use chromium, some other, supplement. I think there's a supplement called blood sugar support from Vital Nutrients. There's a glucose supreme herbal from Designs for Health that we like. We really try to mix it up. So we did those for his metabolics and inflammation issues. And then we initiated the gut healing protocol, which we use GI Resolve from Biotics. I really like that one because it doesn't have any added stevia, but it doesn't have any additives really in there. So I do really like that one as a good baseline gut glutamine powder. And so we put him on this protocol for about 6 weeks, brought him back in. He was told to keep a blood pressure diary and a symptom diary. And as he did this, it was obviously hard. It's always hard to get rid of dairy and gluten if somebody ate that, all the time. But he got rid of everything. He did really well. And his blood pressure diary, you can sort of see his blood pressure started coming down into the 120s. It was pretty good for him. His heart rate was stable. He wasn't having that fatigue as much in the afternoons. We also, with working with his cardiologist, we also reduced his metoprolol to 25 milligrams because his blood pressure was coming down a little bit, just to sort of see what was happening, if there was a big change. So then his fatigue came, was pretty good. So we thought maybe the fatigue was a result of being on the beta blocker. But, it could be a lot of other factors as well, but that was just our working theory. And so after about 6 weeks, when he came back, we were very shocked as, that he was doing so well. He felt really good with just even that first initial protocol that we did. And he actually lost 4 pounds, I believe, which he was excited about because he was having really trouble, losing weight. So what we told him was that 4 pounds was probably that inflammatory weight that he was holding on to because of all of this inflammation mediator circulating around and water weight and whatnot. But he basically, after we still see him in the clinic as follow-up, but the first 6 months, he really did a really phenomenal job staying away from his diet. We did reintroduce gluten first. He wanted to do that one first, and we said, okay, fine. He tried it, and he didn't really feel anything. He kept that going on. Casein, same thing, but interestingly enough, the coffee is what raised, his blood pressure, but the kale caused his joint pains and the headaches due to that. So that's what he sort of figured out in his journey, was that those two were visible symptoms to him that he can actually feel. Some of the other stuff was probably more at a cellular level, but those were the things he was just feeling. But that's him. So we repeated the inflammatory markers, like I said, and they came down. The HSCRP almost came down. I think it was still in the moderate range, but it was pretty close. I think it was like 1 point. I think currently it's about 1.3, whereas when we started, it was probably about 5 almost, 4.9 or something like that. That's what it was when we started. So basically, dietary changes, supplement regimen, improvement of symptoms, markers coming down. You see the results, you do better, basically, because you're seeing what's happening as well as feeling what's happening. So that's that patient. Another patient we had was more of the metabolic path. So we, like I said, we see all kinds of patients, but the focus is cardiometabolic. So this one was a 35-year-old girl, Sarah. She had a history of PCOS, irregular menstrual cycles, insulin resistance. She was told she had insulin resistance, and she had weight management challenges. She had irregular cycles, fertility issues. Her fasting glucose levels were high. They diagnosed her with insulin resistance. That's what she came to me with, and the weight issues. And so we started working through what we would do for her, and we did a full-on hormone panel, metabolic panel. But then I said, actually you should consider doing the food inflammation test, because you don't really associate the two. But when your gut is not working properly, hormone metabolism messes up. You don't have the right microbiome makeup. So let's assess this stuff. We don't think that first off, but it actually did play a big role in her. And we identified her sensitivities to triggers, and she was positive for Candida. And so with her, we really started dealing with getting rid of the triggers. Obviously, we're doing a whole Candida protocol and trying to get that Candida lower so that she would actually get improvement of her insulin and glucose function. Her metabolics overall got better. Hormones, we worked on detox pathways, because that's another big thing, working on the detox pathways to get rid of the metabolites and hormone issues. We customized her foods. Her foods were actually very interesting. She didn't have gluten or dairy. She had egg whites, bananas. She also had kale, which is interesting, and spinach and almond. And I mean, she ate eggs. She made like a smoothie with like egg whites and bananas. I think it might have had spinach. I don't know, but she had a smoothie like 3 to 4 times a week. So that was interesting, and it was hard for her to stop, because that's what she knew to have every day for breakfast. So then we helped her with the meal plan, which KBM also gives a meal plan, which helps them at least have some kind of baseline to see what they can have, because we are going to tell them what they can have. So it's always nice to have nice to see what you can have. We also did nutritional supplement protocol for her for insulin sensitivity, hormone support, and the anti-inflammatory support in addition to the Candida. We just space it out in a phased response, so people are not having to take too much at one time. So we do probably a 2 to 3 month protocol for a patient like this, and then we have maintenance things once we recheck certain aspects of their blood work. So for her, she had restoration of her menstrual cycle. She had better insulin levels and fasting glucose when we did recheck it in about 3 months. And her weight loss, she lost 18 pounds actually. And that was, from her diet. She lost 18 pounds. We did have her do some resistant training. We had her do some exercise, walking, things like that. And she was actually one that we made her do a gratitude journal, or just journal writing. And for her, she also had a stressful work schedule. So this helped her actually, reduce her stress and realize how stress was impacting all of the stuff that she was going through. So that was very helpful for her. So that was just a little additive thing we did with her, is to tell her to keep a journal of whatever she's feeling. So that was something interesting with her and that stress level. And then where did my case 3 go? I don't know where case 3 went. Well, I think I lost a case, but I don't know where that one went. Okay, well, case 3 is interesting. So case 3, I'm going to keep it on this page, but case 3, I'm not sure where that slide went, but so case 3 was a guy named Mike. He's 48, I believe, and his primary reason for coming to us was PVCs. Now, it's very interesting. This has been a recent influx of patients with PVCs that have been trying to approach it a functional or integrative way of dealing with them. And he had gone through everything possible testing wise, all that conventionally with the cardiologist, and he was told he needed an ablation. He was totally against it. Most of the people that come to see, they don't want to take medicine, and I get all that, but he definitely did not want to get an ablation. So he wanted to really figure out why he was having PVCs when there's no real issue in his family that he was aware of that had any kind of arrhythmias or any kind of real chronic cardiovascular issues that he knew of. So we started working, just again, same thing, foundationally. I always start foundational. I do their detailed history. We start foundational. What is happening with the things you can't see or things you can't deal with? So what kind of foods are causing the inflammation trigger, because we think, there's some kind of inflammation pathway happening to cause these PVCs, some sort of disconnect somewhere. So controllable factors, diet. So let's do the inflammation testing. The gut heart, connection. Let's do a study to figure out what the microbiome makeup is. What's the gut barrier panel? What do you have this leaky gut? So leaky gut is important, right? Because you have your gut lining, zonulin is elevated, occlusion is elevated, the stability is off of the gut lining. So instead of being nice and tight, they're going to be open. So all this stuff in the gut starts seeping through into the bloodstream and affecting places that, you may just be more susceptible to. And that can cause irritation of the metabolics, can cause PVC, just any kind of arrhythmia, right? It can result. But for him, he didn't realize that because, like I said, he didn't have any family history of anything that he was aware of. He didn't really feel anything different besides these PVCs. So we got his food stuff, and very interestingly enough, he had, if I'm trying now, I don't have my slides, so I'm trying to remember exactly what he had. He had eggs, he had some fish issues, if I recall correctly. I think it was sardines for him. And what the other big one he had elevated was peaches. He liked to eat cottage cheese and peaches every day. And sometimes it would be multiple times. It was just a quick snack for him, and that's what he ate. So dairy was not the issue, but the peaches, and we realized this afterwards, the peaches part of it was stirring something up in his system where, whatever, resulting in this PVC. So we took it away. I actually told him to take it away for 8 weeks. We had been working on a cardiovascular support for supplement protocol. So we did CoQ10, carnitine, lipoic acid. We just did a protocol to support his cardiovascular status and the micronutrients. So we did assess his micronutrients and we optimized what we could. He did have the MTHFR, a genetic mutation. So we did, adjust his B vitamin, how we did that. But we took away everything, the food wise, and he didn't think peaches would be that big of an issue. It just didn't sound like something that would be causing an issue. Well, his PVCs didn't completely go away. This is about 3 months. It didn't completely go away. But after 3 weeks, or 3 weeks, he wanted to try adding it back in. Well, the PVCs came back with a vengeance, basically. He had them all the time, and he didn't quite understand. He didn't do anything different. We journal it. We tell everybody to keep a journal of everything they're doing while they're doing the initial protocol, just to get an idea of what may be causing certain things. Well, nothing, was changed in that. The peaches were the only new addition. We took it back away. It took a couple of weeks at least to subside the PVCs again. And then he wanted to try it out for himself. And so he took it again and he got the PVCs again. So it was just interesting to see. My cardiology, I would never have associated something like peaches causing PVCs, but who knows? Everybody's different and their bodies are different. So no idea how the, role works. But again, it's inflammation pathway. It's just something that triggered the inflammation. And this caused some disruption, maybe biochemically, maybe micronutrient wise, gut wise, the microbiome, maybe that connection there. I don't know. But peaches was his thing. So, he right now is pretty good. We still have occasional PVC, so there must be something still, but not to the level where he was. He's not needing an ablation right now. So we're trying to prevent him from getting that. And we're trying to do whatever we can to still work at investigating his root cause. But so that's that. Those were some 3 different types of patients that we have. So who are other people that come to see us? Obviously, the people with chronic conditions, cardiovascular, metabolic syndrome, things like that. People that have this unexplained symptoms, dizziness, lightheadedness. We get a lot of ringing in the ear. They come. Then those that are the family histories that are strong and they're trying to prevent their, cardiovascular issues from, coming into their life in the future. So we see them, and just anybody looking for any kind of personalized precision integrative care, because I'm not against conventional medicine, but I think there's a time and place for everything. And we want to make sure we do it the right way and still investigate why somebody's having what they're having. This is from the bottom 4 things are from our website, and this resonates with a lot of people. And it just is something to make them think that, is this why you want to be seen in an integrative or functional medicine clinic? You know, are you tired of chasing symptoms and are ready to get to the root cause? Did your lab test come back normal, yet you still feel terrible, and the only solution to be given is some medications? This is a really big one for us. We actually look at everybody's conventional labs that they've had drawn, and we would really deep dive into their blood work. You really can learn a lot from somebody's blood work, whether, you know, whatever their acidic, alkaline status is, obviously their lipids, their functional, what type of function of the lipids do they have? Are they the good cholesterol? Are they bad cholesterol? Not just the HDL or LDL, but the size and functionality of things. What are their genetics? We do a lot of genetic testing, functional genomics we do, just to sort of see how to best hack that and try to get them the best way of the supplement, or, you know, whatever we have to do, what's the best thing for them. And then, you know, a functional integrative approach takes a lot of commitment and time. So we want to make sure that whoever we see here is willing to make those changes, because giving up gluten, giving up dairy, giving up whatever, maybe kale is easy, maybe Brussels sprouts are easy, but there's some things that are very difficult. Coffee is difficult for a lot of people, but do you have the mindset to make the change? I think once you start seeing either numbers going down or your symptoms getting better, it's much easier to sustain those things in life. But, you know, it's hard just for somebody to make a blanket statement and say, hey, stop this, stop that. So I think in that sense, you have to have the right mindset to work with an integrative or a functional medicine approach to your health. And the people that come here, we see both. Some are not quite ready. They think they are, but they're not. And we work at their pace. So we are very individualized, and we'll work at whatever pace the patient needs. And then we want to make sure they are motivated to make that active role. They need to be an active participant in their own rescue. I heard this from a nurse of mine long ago, and I really like that saying, you have to be an active participant in your own rescue. And it's true. You have to be willing to do everything. You have to be motivated to do everything. But when you are, you will, you know, reap the, you know, benefits of all of that. So those are some of the types of people that come to see us. We also have gut health and all of those other types of patients, but these more from the cardiovascular standpoint. And what we've learned so far working in the functional medicine realm of heart health, learned that, you know, all kinds of testing that you may not think about is important, and we do a lot of it. There's a lot of environmental and toxic metal, you know, that kind of stuff plays a role in cardiovascular inflammation. So those are the full realm of testing that we offer our patients, but we really try to target and tailor it to what their need is and what their capability is. So our strategy is, again, very personalized, very precision for that person. There is no one size fits all for us. We really do work one-on-one with our patients. Finally, we get to the questions and next steps part, but I'm going to try to figure out how to get back to the main screen here, and then we can chat a little bit.
Well, thanks, Dr. D. Appreciate it very much, and thanks for that great presentation and sharing all the details about your very thorough practice. We do have a number of questions, and I'll go through that because I know we're pushing close to the edge of the time limit. But
Yep.
First question was, can you define TMAO and how you use that?
So TMAO is just a heart marker that we just sort of see if it's something released by bacteria. And I'm not going to be the expert in that because I'm not a full expert in that, and I can get you more details of how we use that, you know, separately. But basically, it's a mediator released between bacteria that affects the gut, and that's how we sort of measure that. There's a marker, and then we just sort of try to see if there's a connection between the heart and the gut itself. But
yeah, I know it came out of the Cleveland Clinic, and it's available commercially through Quest and LabCorp now, so you can get it from those places.
Yeah.
Another question was, what testing for neurotransmitter toxicity testing? That was somebody picked that up somewhere along the lines.
Neurotransmitter, the ones I use currently is from ZRT. We just measure, we quantify the excitatory inhibitor neurotransmitters and the excitatory and inhibitory neurotransmitters, and we sort of modulate and balance those two. And the heavy metal toxicity we do through the lab, like heavy metal screens, lead, cadmium, arsenic. We do those. We do environmental testing. We do mold testing. So I don't know if that's what you're just what you want, but feel free to reach out. I'll give you. I'll put in my website and my email at this, and you guys feel free to email me any questions as well if you need to.
Okay, we got another question about what helps lower LPPLA2 levels, and does it ever become normal, in your opinion?
So we did actually have somebody that just a couple of days ago that had a very high play activity level probably 6 months ago. What we've been doing is a very aggressive anti-inflammatory pain, obviously with the diet, getting rid of all those inflammation triggers, but we also have him on high doses of curcumin, high doses of boswellia, stress management, sleep hygiene. We have him on all that. It's basically cut in half. It's still in, so if there was a red, a yellow, and a green being normal, he was from a higher red to now a lower yellow. So it's taken a while, but we are seeing some changes in those numbers. So I mean, it's a hard one to control, so is MPO, but just doing whatever changes we've been doing with his diet and the supplements, I think has brought it down. It has not normalized yet. So I can't tell you if it's complete, and that's just fresh in my mind because it was last week. I can't say it's completely normalized, but I know it has come down. So more than half. So.
Okay, excellent. I know sometimes people think of LPPLA2 and LP(a). LP(a) doesn't move for anything. There's a couple new drugs in clinical trials now. I think 2 companies have them in phase 3 clinical trials. They're pharmaceutical agents. They'll reduce it. I think I've seen as high as like 60%. So stay tuned on that in the future for LP(a).
Yeah, we've been working on some supplements for that as well. So we were trying to figure out what, and there are things that bring it down, maybe aspirin, things like that, help a little bit, but then more of the things that help to thin out the blood and make it smoother endothelial function wise. We've been working on that pathway too. So.
Excellent. And then there was just one last question. It says, why do lipids build up, kind of in the arteries and not the veins and the capillaries? More, kind of a theoretical type of question. I mean, I know I've been 27 years in this living world. I can tell you.
You take it, Casey. You got it.
The arterial walls, the fatty deposits get into the arteries and build the plaque out and build the thrombus and cause the events. The veins, it just, they get cut off, and of course you get peripheral arterial disease and things of that nature when your limbs get cut off. And that's the only thing I could think. But that I've never been posed that question before.
I was gonna say, I don't think I've ever been asked. I mean, maybe the valves or something like that have something to do with keeping the flow going through the veins. Maybe, I don't know.
No, but well, that's all the questions. So that concludes our webinar for today. Thank you all for joining us. Thank you, Dr. D, for your great presentation. We appreciate it very much. And like I said, if you want, you can contact us at info@kbmodiagnostics.com. If you have any questions, we can direct that directly towards Dr. D or myself, cboyd@kbmodiagnostics.com. We will get a recording of this out to you very shortly. So have a great day, everybody.
All right. Appreciate it, everybody. Thank you. And I've also put my email if anybody wants to reach out and ask any other questions they may not have gotten answered. I speak a little bit faster, so hopefully that's not an issue. All right. Take care, everybody.
Thank you.